Good day, everyone. My name is Winnie, and I'll be presenting along with my group members, Morgan Phillips and Henry Joaquin. Today, we'll be discussing allergic rhinitis, a common but often under-recognized condition that affects millions of people each year. Throughout this presentation, we'll cover its pathophysiology, pharmacologic management, safety considerations, and implications for over-the-counter use. Allergic rhinitis is an allergic reaction that happens in the lining of the nose when the immune system overreacts to harmless substances in the air, like pollen, dust mites, or pet dander. When a person with allergy inhales these particles, the immune system mistakenly identifies them as harmful invaders. This triggers the production of a specific antibody called immunoglobulin E, or IgE. These IgE antibodies attach to the mast cells in the nasal mucosa. These cells are responsible for releasing histamine and other chemicals during an allergic reaction. This slide shows a visual breakdown of what's happening during those two phases. The early phase reaction, which happens within 5 to 15 minutes of exposure, the mast cells release histamine, leukotrienes, prostaglandins, resulting in the classic symptoms such as sneezing, itching, watery nasal drainage, and congestion. Histamine in particular increases vascular permeability, causing swelling and a runny nose. About 4 to 6 hours later, the late phase reaction develops. At this stage, more immune cells such as eosinophils, basophils, and T lymphocytes migrate into the nasal tissue. They release inflammatory cytokines like interleukin 4 or IL-4 and interleukin 13 or IL-13, which maintain and amplify the inflammation. This leads to prolonged congestion and nasal blockage. Over time, persistent exposure to allergens causes the nasal mucosa to stay inflamed and hyperreactive, so even small exposures can trigger symptoms. Now that we understand allergic rhinitis, let's look how it's managed. Treatment focuses on controlling symptoms, reducing inflammation, and preventing triggers. The main management strategies include allergen avoidance, which is the first step, reducing exposure to things like dust, pets, and pollen. For your over-the-counter medications, we have mast cell stabilizers such as gromolin, which is best used before allergen exposure or pollen season. For the acute stage, we can use intranasal corticosteroids, antihistamine, and decongestants. And for the prescribed options, we have to use leukotriene receptor antagonists and immunotherapy for long-term control in chronic or severe cases. There are also supportive options like saline rinses or even surgery for chronic sinusitis or nasal polyps. But today we'll be focusing on over-the-counter medications. This brings us to the categories of intranasal corticosteroids and decongestants. I wanted to bring emphasis on triamcinolone or Nasacort, which was the first nasal steroids to go over the counter, and pseudoepinephrine, which requires ID and purchase limits under the Combat Methamphetamine Act, because it can be an active ingredient for strict methamphetamine drug formulation. Next are the antihistamines, one of the most commonly used over-the-counter allergy medications. Overall, histamines are best for relieving sneezing, itching, and watery eyes, but they don't do so much for nasal congestion, which is why we often combine them with intranasal steroids for better symptom control. Emphasis with acetylestine, which was switched from prescription to over-the-counter in 2021. Now, let's take a deeper dive into the medications. Henry is coming up next.
All right. So let's begin with the basic pharmacology of the OTC medications you can purchase for allergic rhinitis. We have several major drug classes: antihistamines, corticosteroids, decongestants, and mast cell stabilizers. Antihistamines, they block H1 histamine receptors. With this, they reduce the amount of sneezing, itching, runny nose, and watery eyes. And their onset of action is usually between 1 to 3 hours, and they come in tablets, liquids, and nasal sprays. Next, we have corticosteroids, specifically intranasal. They inhibit inflammatory cytokines and eosinophils activity to reduce nasal swelling and congestion. These usually start working within the next 6 to 12 hours after ingestion, but the full effect can take around 3 to 5 days, and they're typically administered as nasal sprays. Okay, so when decongestants, on the other hand, they stimulate alpha adrenergic receptors, which causes vasoconstriction and reduce swelling of the nasal blood vessels. They act pretty fast, within 5 minutes to 60 minutes or an hour, and they can be taken orally or intranasally. And finally, we have mast cell stabilizers, and they prevent mast cells from releasing those histamine and leukotrienes, and they are used prophylactically, so meaning before symptoms start, and it take several days to weeks for full effect. When it comes to intranasal corticosteroids, there are two main categories. The first generation, which includes that triamcinolone, or also known as the Nasacort, and the second generation includes budesonide, fluticasone, Flonase, and the Nasonex on mometasone. Common side effects include nasal irritation, burning, dryness, sore throat, sneezing, and occasional nosebleeds. And rare side effects can include nasal septal perforation, delayed wound healing, or mild headaches. Systemic effects are very rare, but they can include those that mild growth suppression in children or the adrenal suppression if overused. Key takeaway is to correct spray technique and proper dosing to minimize these risks. And then moving forward to special considerations, again, in children, we prefer the second generation just because of the lower systemic absorption. But with corticosteroids, we still need to monitor that growth if used long term. And then for pregnant or lactating women, these are also preferred due to minimal absorption and safety with breastfeeding. And in older adults, second generation steroids are also better uh, due to the toleration and cause of less mucosal irritation. They're also recommended on asthma, COPD, diabetes, or hypertension patients because they're a safe alternative to the decongestants. We'll go over it later. They have negligible systemic effects, and overall second generation intranasal steroids are the gold standard for most patients. And moving forward to antihistamines, these are three categories: the first generation, second generation, and intranasal. The first generation includes Benadryl, which is your diphenhydramine, and these are sedating and can cause drowsiness or confusion. And with their second generation, these are your loratadine, cetirizine, or levocetirizine, like your Xyzal, and these are non-sedating, longer acting, and preferred for daily control. And then for the nasal formulation, you have your azolastine or Astapro, which provides fast symptom relief directly at the site. Common side effects can include mild sedation, dry mouth, constipation, or dizziness, and severe reactions are rare, but children or older adults may experience paradoxical excitation or confusion, especially with the first generation drugs. Your special consideration with antihistamines for children, again, we avoid first generation because of the sedative and paradoxical excitation effects. And then for pregnant or lactating women, we only to use them with supervision since older antihistamine may affect milk supply. In adult patients, we must avoid first generation since they do increase those fall risk and confusion. And those with asthma, glaucoma, BPH, or hypertension should also avoid sedating antihistamines like the first generation or combination products with decongestants. And then again, most second generation antihistamines are renally cleared. So we need to monitor kidney function in patients with renal impairments. And then now we're moving on to decongestants. And then with these are your pseudoephedrine or Sudafed, phenylephrine, and the for topical, you have your Afrin or phenylephrine nasal spray. Common side effects are nasal dryness, insomnia, elevated heart rate, restlessness, or tremors. And if overused or more than 3 days, these topical decongestants can cause rebound congestion, such as rhinitis medicamentosa. Um, Serious but rare side effects include hypertensive crisis, arrhythmias, or stroke, especially with chronic overuse. And then for their special consideration for children, decongestion should be fully avoided, especially under 6. For pregnant women, avoid them in the first trimester due to fetal vasoconstriction. For lactating women, they may reduce the milk supply, so we prefer short-term topical options. And then especially with older adults or patients with anxiety, glaucoma, hypertension, hyperthyroidism, or seizures or disorders, we should avoid them fully. Okay. But again, topical forms are safer, but still should be no longer used more than a few days. Last but not least, we have our mast cell stabilizers, and these are marketed as nasal crom. They work by, again, preventing the release of histamine and leukotrienes. Common side effects are nasal irritation, sneezing, mouth throat irritation, or temporary unpleasant taste. With nosebleeds and headaches are being very rare, and also systemic absorption is very minimal, so they're extremely safe to use overall. And as far as special considerations, these are generally safe, but then they do have some practical limitations. They're not approved for children under the age of 2 years old. And then they are going to be a little bit more difficult to use on elderly patients just because they do need to have 3 to 4 times a day as far as dosaging. And then with memory and coordination issues, this must they're probably going to be a little bit more difficult to use. And for someone to already have nasal infections or irritation, it'll delay those healing processes. So with patients needing fast relief, this isn't ideal. Again, this is preferred to be a prophylactic or preventive use. And then as far as overall OTC products estimated in the market, around 4 to 8 are marketed for intranasal corticosteroid products. Decongestants obviously dominate the market with 250 different products. Antihistamines are roughly around 300. First generations, 40 to 60. Second generation, one intranasal antihistamine and 20 to 30 combination products. And then for mast cell stabilizers, there's currently only one approved OTC option, that's your Cromolyn. And this really shows how antihistamines and decongestants really dominate the market. And while the other drug options, which are technically the safer ones, they have fewer consumer choices, right? And then now I'm going to hand it off to Morgan. Thank you.
Okay, so medication safety issues and risk reduction. So when we think about medication safety and allergic rhinitis, the main concerns differ by age group. For kids, long-term intranasal corticosteroids like fluticasone or budesonide can slow growth if systemically absorbed via adrenal suppression through affecting the hypothalamic pituitary adrenal axis and inhibiting the body's production of endogenous glucocorticoids. So this risk can be minimized by using the lowest effective dose and monitoring growth charts. In our older adults, oral decongestants such as phenylephrine can have a cardiovascular complications and raise blood pressure, trigger arrhythmias, and cause urinary retention through sympathetic stimulation of our alpha receptors. So these meds should generally be avoided in patients with known heart disease, hypertension, or urinary conditions such as benign prostatic hyperplasia or BPH. And then finally, our first generation antihistamines like Benadryl are strongly anticholinergic and lipophilic, meaning they can cross the blood-brain barrier, resulting in a sedative effect. So if these meds are used in combination with other meds that patients may take, such as benzodiazepines or routine sleeping pills like Ambien, they can result in serious central nervous system depressant symptoms such as drowsiness, confusion, a delayed reaction time, all the way to more serious complications or consequences such as slowed breathing. So Benadryl can be replaced with safer second generation options such as Claritin or Zyrtec. Right, cost. So cost is the deciding factor for many medications. However, over-the-counter medications can provide a more cost-effective option. So looking at average retail prices, inhaled corticosteroids like Flonase come with 120 sprays and often require on average 42 sprays over a 14-day course, which comes out to about $6.14 per course. Whereas antihistamines such as Benadryl can be taken for 5 days and will result in a cost of approximately $8.16. And then lastly, our oral decongestants such as Sudafed are approximately $6.65. So all three are relatively affordable, but the bigger issue is balancing costs with safety in the right population. So kind of touching on what we just spoke about, but why does over-the-counter availability matter and what are its implications today? We listed out a few benefits and a few risks. But just to reiterate, over-the-counter availability improves access and convenience, can save costs, encourages earlier treatment, ultimately supporting public health. However, it also carries the risk of misuse, safety concerns for certain populations, a delay in diagnosis is possible, and then there are also limits placed on dosage and potency that's highlighting the need for careful monitoring. Just to wrap everything up, as a final overview, there are 4 main meds or types of meds that we will use in terms of treatment for allergic rhinitis. So our intranasal corticosteroids are again our first line because they work directly on the site of inflammation and decrease congestion. Our oral decongestants work quickly but carry higher risk in our older adult population. Then our antihistamines can be sedating or non-sedating if we opt for second generation agents. And then lastly, intranasal antihistamines can provide rapid local relief, though some patients will experience nasal irritation. So in summary, while all these medications can help relieve allergic rhinitis symptoms, safe prescribing really comes down to matching the right drug to the right patient. So that means considering not only cost and convenience, but also age, comorbidities, and overall safety.
Thank you, Morgan. And that's all for today. Thank you so much for listening, everyone.